Dear Chair, dear audience, let me present the 6 months progress of my PhD research about extraintestinal manifestations in inflammatory bowel disease. My name is Ágnes Tímár. I'm a first-year PhD student and a pediatric resident at Heim Translational Pediatric Institute. My supervisor is Katalin Müller and my SMS is Márk Ernádfői. I have a vision to improve the quality of life of IBD patients through proper treatment, and for that, my mission is to assess long-term disease outcomes and treatment options of IBD patients with extraintestinal manifestations. I have 2 ongoing projects. Both of them are focusing on extraintestinal manifestations. In the first one, I'm investigating the frequency of extraintestinal manifestations during advanced drug therapy, conducting a meta-analysis. And my second project is a registry analysis about the relationship between extraintestinal manifestations and the intestinal disease course in children. So I would like to start with my first project and its importance. During the advent of anti-TNFs, they have been proven to be effective in IBD and revolutionized its management. However, 1/3 of the patients experience loss of response within 3 years, and in these cases, new biologicals and small molecules are available. There's a group of patients, approximately 10–25% in the IBD population, who develop extraintestinal manifestations. These patients face a greater challenge in their daily living due to greater symptom burden, higher peer burden, and impaired quality of life. There is a misconception that the successful treatment of the intestinal inflammation will be always sufficient to treat extraintestinal manifestations too. Therefore, it is highly important to cover extraintestinal manifestations with the treatment. I would like to highlight our treatment options very briefly. We have ustekinumab, tofacitinib, and upadacitinib, which all have a systematic effect and are already applied in other immune-mediated diseases. On the contrary, we have vedolizumab, which is a gut-selective drug, and therefore it is expected to have less effect on extraintestinal manifestations. Currently, there is no evidence which of these drugs is the best option to treat different extraintestinal manifestations. Our aim is to determine which of these drugs is associated with the lowest frequency of new extraintestinal manifestations. Here you can see our clinical question, that what is the frequency of new extraintestinal manifestations during the use of different second-generation drugs? And we are investigating IBD patients who are on second-generation treatment. Our primary outcome is new extraintestinal manifestation, and the secondary ones are improvement and worsening of already pre-existing extraintestinal manifestations. Our hypothesis is that the frequency of extraintestinal manifestation is the highest in patients who are on gut-selective biologicals. We conducted our systematic search on the 15th of November in 4 databases, which resulted in more than 13,000 hits. During the selection process, we were able to reduce it to 121 eligible articles. So let's proceed with the results. In general, I would like to say that in all of my forest plots, we are investigating the frequency of extraintestinal manifestation, and proportion was used as a measure of effect in all cases. My first plot is about the proportion of new joint involvement during advanced drug therapy. We formed subgroups based on the applied drug type, as you can see in this case, vedolizumab and ustekinumab. The overall proportion in case of vedolizumab was 8%, whereas it was 5% in the ustekinumab subgroup. So this is neither clinically nor mathematically significant. The outliers here, you can see are the results of longer follow-up times and the inclusion of already pre-existing extraintestinal manifestations. In my second forest plot, we are also investigating joint involvement, but here the improvement of them. And we were able to form 3 subgroups here, vedolizumab, ustekinumab, and upadacitinib. Here you can see that the overall proportion of improvement with vedolizumab is 40%, 48% with upadacitinib, and 50% in the patients treated with ustekinumab. So again, the difference is not significant here. In my third forest plot, we are investigating the proportion of new erythema nodosum. In general, we can say here that this manifestation is really rare, and the overall proportion is 1% in both subgroups. My last forest plot is about the proportion of improving erythema nodosum during advanced drug therapy. Here we could only include 8 articles covering 52 patients, so it's a small sample size. but the proportion of improvement was 62% in the vedolizumab subgroup and 70% with the ustekinumab. So again, that's not a significant difference. We have several strengths and limitations as well. I would like to highlight that we included a relatively high number of studies, and most of them were published in the last 5 years. And furthermore, we provided a detailed subgroup analysis. As a limitation, there are no RCTs available in this topic, and the follow-up times are really heterogeneous. And moreover, the studies report about extraintestinal manifestations very differently. In conclusion, we can say that new extraintestinal manifestations are rare, and the improvement of both joint involvement and erythema nodosum seems to be similar during ustekinumab and the gut-selective vedolizumab treatment. For a practical implication, we can suggest that that the fear of new extraintestinal manifestations should not influence our drug of choice, and there's no need to ignore vedolizumab and switch from that to another drug in case of a joint involvement on erythema nodosum is present. As a research implication, we suggest that more RCTs are needed in this topic with the inclusion of higher number of patients who have extraintestinal manifestations, and we strongly suggest to come up with a standardized reporting system for extraintestinal manifestations. I'm already working on the manuscript. I've finished the methods part, and the whole article is planned to be finished until the 18th of April. So in the remaining time, I would like to introduce my second project, which is a registry analysis about the relationship between extraintestinal manifestations and the intestinal disease scores. Extraintestinal manifestations are even more frequent in the pediatric IBD population. 25–40% of them develop at least one during their lifetime. However, little is known whether these patients experience more severe intestinal disease course. We found a recent meta-analysis which showed that these patients have a higher risk of undergoing IBD-related surgery and receiving biological therapy. This meta-analysis included mostly studies with adults, so we are interested whether the situation is the same in the pediatric population. And there are already some suggestions in the literature that early aggressive therapy could prevent long-term complications. So our aim is to provide a descriptive analysis of the extraintestinal manifestations among Hungarian children based on the HUPIR registry. And furthermore, to analyze the association between the presence of extraintestinal manifestations and the intestinal disease course. And for that, our clinical question is whether there's an association between extraintestinal manifestations and the intestinal disease course in pediatric IBD patients. And we will compare those who present an extraintestinal manifestation at diagnosis and those who develop the first one during the follow-up with those who have no extraintestinal manifestation at all. Our outcomes will be relapse rates, therapy failure, surgery rates, and steroid dependence. We hypothesize that patients with extraintestinal manifestations have a higher risk of poor prognosis of IBD. And by answering this question, we plan to define the role of extraintestinal manifestation as a prognostic factor. So this is the summary of my two projects. I plan to submit the first one in May and the second one in August. And I would like to finish my presentation with a quote that the best preparation for tomorrow is doing your best today. And thank you for your kind attention.
Thank you for your presentation. You mentioned that we have to ignore the vedolizumab in some cases. And what are the advantages of the vedolizumab as a gut-selective drug?
As you mentioned, it's a gut-selective drug, and therefore it has less side effects, and it could be more beneficial in vulnerable populations, for example, elderly patients, or who underwent chemotherapy or are immunocompromised because of other reasons.
You said that one of the reasons behind the heterogeneity can be the different follow-up times, such as for my research. Do you plan to consider it, to make an analysis of them?
Yes, we plan to divide the studies. They have short And long follow-up time, short means here basically the induction phase of the drug.
Congratulations, perfect talk. I'm just wondering, maybe I missed it somewhere in the presentation. You included the studies of the patient that were already on the anti-TNF alpha, or they failed anti-TNF alpha, and then after they get the vedolizumab or the tofacitinib and so, or it was also the studies that include like the top-down therapy from the, let's say, novel IBD drugs.
So most of the, I would say that 95% of the patients were anti-TNF experienced in all studies.
So they were failed anti-TNF?
Yes, mostly. So in some cases, vedolizumab was as a first-line treatment, introduced as a first-line treatment, but that's just really rare.
Okay, thank you. And just one small question: did you also look for the hidradenitis suppurativa patient or complication?
No.
Thank you.
Have you studied the oral plaque, as I know that is more frequent than erythema nodosum?
Yes, we investigated stomatitis in these patients, so we will have forest plots for that as well. But unfortunately, there are not that many results, although I think that's more common than erythema nodosum.
Okay, thank you.
Ask about the registry. How does it work? Just how should we imagine that? How many patients are there? How long time? Everybody who treats IBD patients, they send data, or just certain centers?
Yeah, so it is the Hungarian Pediatric IBD Registry. It was launched in 2010, and it is a prospective follow-up registry, and it involves 27 centers from across the country. And there are 2,300 patients in this registry now.
Can we go back to your last forest plot? In this one, I mean, there is quite a wide range. I mean, this is my stereotype question, you see, that when you see this kind of wide range of responses, that do you have any clue on this, that why do you get actually those wide range? Different kind of treatments, different kind of state of disease, different kind of, I mean, cycle of the disease, or what? Or different kind of measurements?
Yes, one of the reasons that some studies are outliers, for example, Abu-Bakr study, there the follow-up time was really long. So since it's a prevalence study, I think it's understandable. And in case of the Patel study, which is in the vedolizumab subgroup, they, as you can see, they had a really small sample size with 6 patients, and all of them improved. So, yes, there are a couple of reasons behind them.